Good afternoon. My name is Katia Bilardo, and it's my pleasure to discuss with you microcephaly, a practical approach. I have no conflicts of interest to declare. Microcephaly has got a prevalence of 0.5%, 1 in 200. And in the prenatal period, we use two different head circumference thresholds. One, defined as a fetal head circumference of equal or more than 3 standard deviations below the mean for gestational age, to diagnose microcephaly. And the second one, a milder, defined as a fetal head circumference of equal of more than 2 standard deviations below the mean, as a cutoff prompting investigations. And these investigations will be various. We will discuss them. And the most important one is neurosonography that will give us a insight into the fetal brain, because the true microcephaly obviously relies upon abnormality found in the fetal brain. In the postnatal period for pediatrician, true microcephaly refers to cephalic biometry of more than 3 standard deviations below the mean for age and sex. There are different types of microcephaly that can be primary, acquired, metabolic, syndromic, or secondary. In routine practice, any decrease in cephalic biometry to below the 5th of the 3rd centile raises suspicion of underlying microcephaly. But fortunately, the majority of these cases will pertain idiopathic reduction in head size, which is usually mild. Well, we know that head size can vary between extra small to large, and all the individuals will belong to what we define as normality. So when we find a mild decrease in head size, the first thing we should do is to look at the head of one of the parents. And it's more likely to find a small head by parents like this, that the fetus has got a small head, than by parents like this. Although in this Chinese cartoon it's known that a father with a small head can bear a child, but can have a child with a big head. What is very reassuring is the fact that head circumference between 2 and 3 standard deviation below the gestational mean and normal brain anatomy is not a particular risk factor for later abnormal neuropsychological development, as pointed out by this paper of Stoller, Poria, et al. True fetal microcephaly is associated sometimes with morphological anomalies of other anatomical districts that could belong to complex disorders such as syndrome that can have normal or abnormal chromosome, or it may be exclusively associated with cerebral anomalies. This seminal paper by Guibault and Lacalme, published in 2016, gives us some diagnostic tools to elucidate cephalic biometry and fetal microcephaly by applying a systematic analysis of the central nervous system. And I will use some of this approach further in the presentation. So in the clinical approach, the first and most important thing is to think of the context. Well, the family history, the past obstetrical history, the anamnesis, whether the mother has had recent trips abroad, whether she has had a fever, whether she abuses substances, whether we are dealing with a monochorionic twins pregnancy where one of the twin may have died. And obviously also to take into account the result of previous examination, like screening for aneuploidies, and if necessary, extend this investigation, and obviously screening for infections. A second very essential step is to determine the severity of the decreased cephalic biometry and to perform a longitudinal follow-up. There is a discussion which curves should we use, and this paper from 2019 has analyzed the merits of various curves and has concluded that the WHO reference curve appears to be better in reducing the cases of microcephaly that are misdiagnosed, and therefore it could be very useful in population screening. Whereas Intergrowth 21 has a more significant positive predictive value, it could be better indicated for use in formulating the final diagnosis in reference centers. It's also very important when we evaluate a decrease in head size to look at the global fetal growth. If besides a small head size, there is also a small abdominal circumference, and by applying additional investigation like Doppler, we see that there are abnormal uterine arteries and abnormal fetal flows indicative of redistribution, then we know that the origin, the cause for this reduced head size is placental insufficiency, early fetal growth restriction. There are also cases where we see a reduction in head size and also in other fetal districts, but the umbilical artery is normal. There is even a normal or increased amount of amniotic fluid. There may be other somatic anomalies, and the uterine artery is normal. In this case, we should suspect then a genetic growth restriction, a genetic reduction in the size of the fetal head, as we see commonly in trisomy 18 and in trisomy 13, and in trisomy and also in triploidy, although we know that in triploidy there is an even more reduced abdominal circumference with respect to the reduction in the fetal head size. There are also other genetic syndromes that are known for their association with a small head size. Usually in these cases, the brain anatomy is normal, and these are conditions that can be diagnosed prenatally, especially because they run into families, because there are other siblings affected and targeted investigation is applied. In any case, it's important when we are a little bit lost and there is a small head size and no obvious brain anomalies or very subtle other somatic anomalies, that we rely with our geneticists who are aware of the possibility that it could be a chromosome 1p36 deletion or Adams-Oliver syndrome, Bloom syndrome, Cocaine syndrome, and Marden-Walker syndrome, all known for their association with small heads. And then obviously what we will do after we have found out that there is a small head, to proceed to a global brain investigation. One of the areas that is very important to analyze is the pericerebral space. We know, in fact, that investigation of the subarachnoidal space may provide an etiological clue to the diagnosis of the underlying cerebral pathology. In fact, we know that in most severe encephaloclastic lesions, the pericerebral space is enlarged, like for instance in CMV or lissencephaly. We can investigate the pericerebral space in various planes, sagittal or axial, but what we use really to quantify the increase in the subarachnoidal space is a coronal view, where we measure the shortest vertical distance between the calvarium and the cerebral cortex. And these should be in between 1.5 and 6 millimeters, with a mean of 3.3 millimeters, as indicated by this normal range developed by Gustavo Mallinger. When this measurement is abnormal, we should indeed suspect a severe condition and then obviously proceed to a deeper kind of brain investigation, as I will discuss later. Another element that in a screening setting we want to investigate is the midline. Well, we know that when the midline is absent, completely or partially, we should suspect holoprosencephaly, and especially these two types, alobar, like in this case of semilobar holoprosencephaly, are associated with a small head. When there is an absence of the cavum septum pellucidi and there may be also a fusion of the anterior horns, associated with microcephaly, we should think of semilobar holoprosencephaly and make a difference between these and the septo-optic dysplasia, where the optic chiasm and the optic tracts may be reduced in size. We know that when the head is small, it's normal that also the corpus callosum is hypoplastic. However, the association between small head and corpus callosum anomalies, like for instance, thin and dysgenetic corpus callosum, where we will see that there is an absent cavum septum pellucidum, and there may be also the typical teardrop sign, in a context where the mother is known for substance abuse. And there is also a characteristic abnormal profile with a longer upper lip. We may suspect a fetal alcohol syndrome as cause for the development of the microcephaly. Another landmark which is very important to investigate is the posterior fossa, to see whether beside the head also the transverse cerebellar diameter is small and has a normal shape. This is in order to exclude pontocerebellar hypoplasia. There have been some formulas that are suggested in the literature for predicted transverse cerebellar diameters in relation to the head circumference. In this case, we see pictures of Emanuel syndrome, a rare syndrome, which is a part of the pontocerebellar hypoplasia. In this case, we see by MRI that there is, besides small cerebellar size, also a reduced size of the brainstem, pontovermian hypoplasia, as also indicated here, together with a reduction in the transverse cerebellar diameter. So this could be also a diagnosis that we could be faced with. Another landmark that we should inspect in a global inspection of the fetal brain is the Sylvian fissure, that we know is a main marker of normal cortical development. And we see in recent papers that the investigation is performed on coronal views of the brain. And here we see a schematic representation of the maturation with gestational age from 18 weeks, 21 weeks, 25 weeks, 30 weeks of the Sylvian fissure. And by inspecting these views, we can really apply a cortical grading of the Sylvian fissures. Originally, this cortical grading was done on axial views. This is quite of a landmark paper by Pistorius in 2010, was observed the maturation of the Sylvian fissure from shallow indentation to obtuse angular shape, what we will find typically in the mid-trimester scan, to a more complex morphology, up to a complete closure, operculization towards the end of the pregnancy. While dealing with the case of microcephaly, is very important observing the Sylvian fissure to see if there is a lack of development of the anterior margin of the Sylvian fissure. We see here the difference of the anterior margin shape as compared to a normal case. because this could be a clue to frontal hypoplasia and therefore provide the background for the microcephaly. As I said, neurosonography is an essential investigation, possibly together with MRI, if we consider that this is necessary, to identify malformation of cortical development and also to better identify the disastrous result of infections of vascular accident. In case of malformation of cortical development, like lissencephaly and polymicrogyria, at ultrasound inspection, the brain surface may appear smooth, and this smooth aspect can be associated to both lissencephaly and polymicrogyria, that we know are very, very severe conditions. And in case of classic events of the brain that we may also be able, obviously, to observe on 2D examination, 3D examination, and especially transvaginal examination of the fetal brain may reveal some very subtle features, like, for instance, the presence of heterotopias in the lateral ventricles, or very echogenic lining of the ventricles, of hemorrhage, like in case of a CMV infection, or scattered echogenicities in case of a Zika infection. Well, all kind of infection can give rise to echogenicity. And in case of vascular accident, we will really see a massive loss of brain tissue of the cortical mantle, with a profound modification of the normal brain anatomy. Referring to infections, we know that they have a different impact on the fetal head growth. CMV can produce microcephaly. The most severe form of microcephaly is produced by Zika, but also toxoplasmosis and congenital rubella can impact significantly the fetal head growth. And to conclude, I want to refer to this paper from an Israeli group that points out to the difficulties in prenatal diagnosis of fetal microcephaly. There are, in fact, false positive diagnoses. These are quite common when there is a vertical deformation, an acrocephalic shape of the fetal head. And in that case, it could be possible, and it would be advisable, to use also this diameter, which is performed on a sagittal view of the fetal head, which is the distance from the cranium to the foramen magnum. That could increase the positive predictive value by correcting the suspicion of microcephaly in case of a vertical deformation of the skull. But there are also possible false negative diagnoses. In fact, a prenatal diagnosis of microcephaly by serial sonographic measurement of the fetal head circumference should be regarded with caution, because there could be cases where the deflection in head growth appears only very late in pregnancy or even after birth, and this may result in a false negative diagnosis of microcephaly before birth. In conclusion of these talks, microcephaly is a sign and not a diagnosis. Mild microcephaly cases with normal brain anatomy are mainly idiopathic and have a good prognosis, or may rely upon other diagnoses, like, for instance, growth restriction or other causes. Family history, anamnesis, infection screening, and genetic investigation are vital as part of the workup in fetal microcephaly. In case of non-completely reassuring and suspicious general brain examination, is mandatory to proceed with a neurosonographic examination and possibly also MRI. Consultation with the geneticist is important to exclude and identify rare syndromes. And it's important that we try to reach a diagnosis within the terms for legal termination of pregnancy. And this varies a lot among countries. And unfortunately, false negative prenatal diagnosis of cases developing late in pregnancy or only after birth are possible. And I thank you very much for your attention. The paper is now open for questions at the time of the discussion. Thank you very much.